Now browse your slides.
Bismillahirrahmanirrahim. Herpes simplex. I'm Dr. Ahmad Baid Khan, PGI Community Medicine Department. My supervisor, Professor Dr. Saira Afzal. Learning outlines, causative agent, global burden, clinical presentation, diagnosis, treatment, prevention, complications of genital herpes or herpes labialis. Introduction. Infection with herpes simplex virus, known as herpes, is common globally. HSV type 1, oral to oral contact, oral herpes, also cause genital herpes. HSV2, sexually transmitted, cause genital herpes. Both are mostly asymptomatic or unrecognized but can cause painful blisters or ulcers at the site of infection, ranging from mild to severe. Infection is lifelong and symptoms can recur over many years. Some medications are available to reduce the severity and frequency of symptoms, but they cannot cure the infection. HSV1 problem statement. In 2016, 3.7 billion people under the age of 50 or 67% of the population had HSV1 infection. Most HSV1 infections are acquired during childhood. People who already have HSV1 are not at risk of reinfection, but they are still at risk of acquiring HSV2. HSV1 sign and symptoms. Oral herpes infection is mostly asymptomatic. Cold sores and herpes labialis symptoms can include painful blister or open sores in or around the mouth. Infected people will often experience a tingling, itching, or burning sensation around their mouth before the appearance of sores. Stage 1 tingling, itching, or burning. In stage 2, blister formation. Stage 3 presented with blister burst. Stage 4 is scab formation, and stage 5 is healing stage. HSV2 problem statement. Genital herpes caused by HSV2 affects an estimated 491 million, 13% people aged 15 to 49 years worldwide, 2016 data. Genital herpes symptoms. First, incubation period, which prolong from 5 to 14 days after sexual contact. Initial episode resolve within 2 to 3 weeks. Latent stage, virus travel to nerves and remain inactive. Recurrent episode, itching, tingling, or pain in the buttock, legs, or hips. Pre-DROM virus travel through nerves to the skin surface, illness, stress, sunlight, and fatigue, menstrual periods. Genital herpes clinical presentation. Initial episodes include first herpes outbreak is most severe and symptoms tend to be more severe. Blistering or ulcerative lesions on the external genitalia. Systematic symptoms include fever, headache, malaise, myalgias, usually in the first 3 to 4 days. Local, there may be pain, itching, dysuria, vaginal or urethral discharge, and tender inguinal lymphadenopathy. First episode can be primary, in which the person is seronegative for HSV antibodies, occurring after an incubation period of within 5 to 14 days of sexual contact. Initial episode refer to individual who have the lesion for the first time but already have antibodies to HSV2, indicating past asymptomatic acquisition of HSV2. Although this would be the person's first recognized episode, it would not indicate recent acquisition. Examination findings sign. A group or cluster of vesicopostular or ulcerative lesions is observed on the external genitalia and usually used as clinical indicative of genital herpes. Started as papule or vesicle that spread rapidly. Multiple small vesicular lesion may coalesce into large ulcers. Since the ulceration of herpes is shallow, residual scarring from these lesions is uncommon. However, when a person has a typical appearance of group of vesicle or gives a history of recurrent ulcer, a presumptive diagnosis of genital herpes can be made and treatment tailored appropriately. Among immunosuppressed individuals, these ulcers may persist and continue expand laterally and superficially for a considerable period of time if not treated. Recurrent genital herpes tend to be milder than the initial outbreak, tend to have more localized symptoms, itching, recurrent ulcers, and mild pain. Duration of the episode averages between 4 and 5 days, but may as long as up to 12 to 15 days. Pregnancy and herpes. Women who have their first outbreak of genital herpes near the time of delivery are at risk of transmitting herpes to their newborn. Pregnant women with symptom of genital herpes should inform their healthcare provider. Preventive antiviral therapy with acyclovir is often recommended for women with one or more recurrence during pregnancy. A cesarean delivery is usually recommended in women who experience an outbreak at the time of labor. Genital ulcer disease syndrome, the relative prevalence of positive organism for genital ulcer disease varies considerably in different part of the world and may change dramatically over the time. Currently, however, HSV2 and HSV1 have become the commonest positive agent of genital ulcer disease in many parts of the world. Other causes presenting with genital ulcer disease are T. pallidum, syphilis, primary syphilitic concurs, C. trachomatis, serotype L1 to L3, lymphogranuloma venerum, H. tucri concrete. Diagnosis based on individual's medical history, their sign and symptom, and the result of test. Different diagnosis of genital ulcer using clinical judgment has been shown to be inaccurate in over 50% of cases, even be experienced clinician. Management of people with genital ulcer disease must be based either on laboratory-based etiological studies or a syndrome approach guided by periodic evaluation of the positive agent at the local setting. Laboratory diagnosis of genital herpes. Molecular testing PCR of HSV DNA from swab of genital lesion is the most sensitive and specific test. Using a combined HSV and T palladium PCR when available would be of added benefit to implicate or exclude syphilis at the same time. PCR assays have also been developed for HSV1 and HSV2. Culture enable replication of the virus for determining resistance to antiviral therapy and for confirming diagnosis, but results take about 2 to 4 days. Detect the virus in only about 50%. The culture is more likely to detect the virus when ulcers are new and open as compared to when they are older and healing. Crusted lesions give the lowest yield, more sensitive when individuals experiencing an initial episode than an individual experiencing a recurrent episode. Serological test used when a person has no visible ulcer but has a history of genital ulcer in the past. Having a positive test for these antibodies indicate that the person was infected with the virus at some time in the past. Antibody testing may be negative early during the initial episode of infection. Since antibody formation take a few weeks, the antibody tests remain positive for life. Routine screening for HSV1 or HSV2 is not recommended. Blood test may be helpful for couples if one person has a history of genital herpes and other does not. In if the partner has not been infected, then it is important to discuss ways to prevent transmission. Type specific antibody test can distinguish between HSV1 and HSV2, help to predict the likelihood of future recurrence given that type 2 recur more frequently than type 1. Treatment of genital herpes. First line option is for primary infection, acyclovir 400 mg orally 3 times a day for 10 days. Effective substitute for primary infection is Valaciclovir 500 mg twice a day for 10 days. For pregnant and breastfeeding women and people younger than 16 years, use acyclovir only when the benefit of outweighed the risk. The dosage is the same as for the primary infection in non-pregnancy. Recurrent infection episodic therapy include acyclovir 400 mg orally 3 times a day for 5 days. Recurrent episode for effective substitute is Valaciclovir 500 mg twice a day, and for pregnant and pregnancy recurrent infection therapy include acyclovir 400 mg orally thrice a day. For suppressive therapy, for first line option is acyclovir as well 400 mg orally twice a day, and for their substitute is famiciclovir 250 mg orally twice a day for suppressive therapy of recurrence, and for pregnant and breastfeeding women acyclovir 400 mg orally twice a day. Prevention. Symptom of oral herpes: avoid oral contact with other, including oral sex or sharing objects that touch saliva. Symptom of genital herpes: abstain from sexual activity while experiencing symptoms. Both HSV1 and HSV2 are most contagious when sores are present, but can also be transmitted when no symptom are felt or visible. For sexually active people, consistent and correct use of condom is the best way to prevent genital herpes or other STIs. HSV infection can still occur through contact with genital or anal areas not covered by the condom. Medical male circumcision can provide lifelong partial protection against HSV2 infection as well as against HIV and HPV. People with symptoms suggestive of genital herpes should be offered HIV testing. A recent update: acyclovir resistance in herpes simplex viruses, prevalence and therapeutic alternatives. Abstract: herpes simplex, the causative agent of recurrent orofacial and anogenital infection, can cause significant morbidity and mortality in both immunocompetent and immunocompromised individuals. In immunocompromised patients, HSV tend to be more persistent with chances of dissemination. The nucleoside analog acyclovir has drastically improved the management of HSV infection, although acyclovir resistance strain have been reported in the clinic. We perform a systematic search to summarize the prevalence data reported in both the immunocompetent and immunocompromised population, defining the global prevalence of acyclovir resistant in HSV infection is hampered by high variability in methodology, patient selection, study design, and treatment history among the studies. Acyclovir resistance HSV in frequent in the incompetent population, generally below 1%, irrespective of treatment history, expectation or infection in at immune privileged sites such as cornea, where frequent recurrence and extensive acyclovir therapy favor the emergence of acyclovir resistance. Higher frequency of acyclovir resistant HSV infection are reported among immunocompromised individuals, with the highest prevalence seen among the uh, hema, hematopoietin stem cell transplant recipient. All antiviral approved for the treatment of HSV infection have the same target, the viral DNA polymerase, and cross resistance to different antiviral have has been described, complicating therapy of acyclovir resistant strain. In this review, we will discuss acyclovir mode of action, mechanism of resistance, prevalence of resistance, and alternative antiviral treatment for acyclovir resistant HSV infection. Herpes simplex virus and varicella zoster virus infection. Cancer patient. Abstract herpes simplex virus and varicella zoster virus are alpha herpes viruses that establish lifelong latent infection neuronal ganglia after primary infection. Periodic reactivation of these viruses result in recurrent infection that can have significant impact on patient quality of life. HSV commonly cause oral and genital mucocutaneous infection, whereas varicella is responsible for varicella chickenpox and herpes zoster shingles. But uh, but cancer patients are at particular high risk of complication including dissemination and visceral infection due to impaired cell-mediated immunity, while diagnosis of more common HSV and VZV infection is frequently clinically based. Immunocompromised host may have atypical skin presentation or visceral involvement. Thus, diagnostic confirmation using virus-specific tests such as PCR or immunohistochemical staining is crucial in some cases. Oral acyclovir, valacyclovir, famiclovir are usually used for mild to moderate infection, and intravenous acyclovir is the drug of choice for the severe and dissemination infection. Forecast can be used when acyclovir resistance is confirmed or suspected. Pharmaceutical prophylaxis against HSV and VZV should be considered in high-risk cancer patients. Currently, there is no commercially available vaccine against HSV, and but VZV vaccine are available to prevent varicella and zoster. MCQ. Question number one: a newly married lady has sort of lesion on her genital area for some days. On the history, revealed that her spouse got infected with genital herpes for a month. On clinical examination, how will you rule out HSV2 from other disease causing the genital ulceration? Option A is pus coming out from the urethral meatus. B is vesicular ulceration on the part of the body as well, like lips, face, and heads. C grouped vesicular lesion on vulva. D painless, firm, round, and small nodule on vagina. E is painful red colored bumped in the genital region that become ulcerative. The correct answer is
E.
C,
E.
C, grouped vesicular lesion on vulva. Question number two, a 20 years old boy contracted genital herpes. Various antiviral drugs are available to treat HSV2. Which option is not correct regarding the treatment of genital herpes? A is there is no cure for herpes. B, infection once give a lifelong immunity. C is antiviral medication cannot prevent outbreak. D, antiviral medication cannot shorten outbreak. E is antiviral medication cannot prevent transmission. The A is correct option. Question number three, a 16-year-old girl has grouped vesicular lesion on her lower lip for the first time in her life for 3 days, along with itching and burning. You suspect that she got infected with cold sore. She is worried about the future sequel of this disease. How will you counsel her? A, it progresses to permanent scar in 40% people. B, keloid is common complication. C, it can also present exactly the same in your later life again. D, you can get the lesion on genital area later in your life. E is vaccination can prevent recurrence. Uh,
C.
D is the D is the right option. Question number four. A 20-year-old male has genital ulcer for 3 days who recently visited Thailand. He has positive PCR for HCV DNA. How will you advise her to take which precautions to control its spread to other individual? A. Do not share utensil with anyone. B. Wear face mask while going to public places. C is do not share his personal toothbrush, shaving blades, scissor with anyone. D, do not donate blood. E, have protective sex by using condom. Uh,
E.
E
C.
is, yes, E is the right answer. Question number five, choose the correct option regarding genital herpes in female. A, women are affected twice as compared to men. B, circumcision male has no role in preventing transmission. C, once contracted can be cured with medication or vaccination. D, no risk of transmitting infection once the symptoms are relieved. E, recurrent infection tend to be intense and severe.
E.
A is the right answer. A 30 years old diagnosed case of HSV2 has active genital symptom outbreak of genital herpes. She experienced them 7 times during the past 12 months, which are worse, and she cannot accomplish her duty well. What is the best suitable treatment for her? A is eradication therapy, B is episodic therapy, C is palliative therapy, D is suppressed therapy, E is radiation. D is the right answer. Question number 7. A pregnant lady during her 37th week of gestation developed genital herpes for the first time in her life. What medical management will you offer for this lady? A. C-section is preferred. Option B. Cannot prescribe her antiviral treatment now. C is a course of oral acyclovir for 10 days after delivery. D. Topical acyclovir twice day for 10 days. E is wash the genital area twice daily with chlorohydroxine will not transmit infection to newborn. Correct answer is A. Question number 8. A physician advised again oral acyclovir 400 mg thrice daily for 5 days to patient who has a symptom outbreak for the third time during the last 6 months. What is the advantage of episodic treatment? A. Decrease the duration and severity of the illness. B. Reduce the frequency of outbreak. C. Decrease the frequency and duration of recurrence. D is reduce the risk of transmitting HSV-E is given in less dose than suppressive treatment. The, the correct answer is A. Question number 9. In setting where laboratory investigation are not available to detect HSV-2 infection on the same day, which management strategy is the best for one patient to recurrent vesicular eruption on the same day? A. Hold the treatment for 1 day to wait for lab report. B. Continue treatment for both HSV-2 and syphilis. C. Start the antiviral treatment on the same day. D. Treat with topical antiviral initially and then with oral antiviral after the lab report. E. Refer to the facilities where lab reports can be viewed on the same day. Correct answer is C. Question number 10. Genital herpes tend to occur again and again if a person once got infected. What is true about recurrent infection? A. First episode in which the person is seronegative for HSV antibodies occurring after 5 to 14 days of sexual contact. B. Initial episode in which person has lesion for the first time but already have antibodies to HSV2. C. Tend to be more severe than the initial outbreak. D. Tend to have more systematic symptoms. E. Blister formation may follow symptom of itching, tingling, and burning. Anyone want to answer this question?
B.
E is the right answer.
E, E.
Yes, E is the right answer. This is the key of all the question. These are the references through which this presentation has been made. And thank you. Here is the link of YouTube channel. You can find this presentation by clicking this link. Thank you.